Okay, I think we'll get started. Good afternoon, everyone. My name is Mehreen Hassan, and I work in education services at CAMH. I hope you're all enjoying the conference, and I'd like to welcome you all to this session on slow-release oral morphine as an independent or adjunct treatment for OUD. And I'm really pleased to be here to introduce our speaker for this session, Karen Cheema. Karen Cheema is a nurse practitioner at the Center for Addiction and Mental Health. Her areas of interest include improving access to effective care for people who have mental health and substance use disorders. So I'd like to give her a very warm welcome and a warm welcome to all of you as well. Thank you for joining us, and I'm going to pass things on to Karen now.
Thank you so much, Mehreen, and welcome everyone to this session. I have included links for the Medify recommendations for use of slow-release oral morphine as OAT that were published last year, and the mainly recommendations that are going to be going through in this presentation, as well as the new BCC-SU opioid treatment guidelines that were published in November 2023. I have no disclosures to report. I am one of the co-authors of the Medify recommendations for use of slow-release oral morphine as opiate agonist therapy. And I will be providing reference for all the academic information that I'll be sharing. I will be discussing off-label use of slow-release oral morphine, and the presentation has been reviewed in advance by the conference scientific planning committee, and I welcome any questions and comments people have about both the Medify recommendations as well as the information that I'm presenting today. I hope that by end of this session today, you guys are able to describe key recommendations for use of slow-release oral morphine as opiate agonist therapy, as well as feel comfortable to initiate SROM as an independent or adjunct treatment following updated titration and induction protocols, and gain a comprehensive understanding of switching between different OAT medications. Just a brief introduction, which most of you here already are aware of, that in light of escalating opioid-related deaths associated with fentanyl and other contaminations in the unregulated drug supply, it's really crucial to ensure that people who use drugs have rapid, low-barrier access to effective person-centered care. And despite the significant advances in substance use care, engagement and retention in treatment unfortunately continues to be a challenge for a variety of reasons. And the risk of unregulated toxic opiate supply makes it very important that people who are engaging in care who wants to start OAT, that they have access to as many OAT choices as possible. And for this reason, we think that buprenorphine, methadone, and SROM should all be available as options for people who want to start OAT. In terms of the previous published guidelines, just a refresher where the recommendations stand. The CRISM guidelines that were published in 2018, which were the national guidelines for the clinical management of opioid use disorder, they strongly recommended using buprenorphine as the first-line opiate agonist treatment, mainly because of its better safety and side effect profile compared to methadone and SROM. And methadone was recommended as a second line if buprenorphine didn't work, or if first line if buprenorphine was contraindicated. It did suggest that SROM could be considered as an alternative or adjunct OAT option. Similarly, the CAMH synthesis of Canadian guidelines for treating opioid use disorder that were published in 2021 recommend using buprenorphine, methadone as first-line treatments and considering SROM if both of these are not options, or if a trial on these medications has not been helpful. The British Columbia Centre on Substance Use, they published their revised updated guidelines for clinical management of opioid use disorder in November 2023. And they recommend going away from the first, second, third line approach, and recommended prescribers to work with each individuals to determine which OAT medication is most appropriate for them based on the individual factors. In terms of the Medify recommendations, just a brief development process. It was a team of 7 people, 5 with clinical expertise of using and prescribing SROM, 3 physicians, 1 nurse practitioner, and 1 pharmacist, as well as 2 people with lived and living expertise of being on SROM as an opioid agonist treatment. And the group reviewed all the existing literature on evidence and indications for SROM as OAT, as well as strategies for initiating and titrating SROM. Those who are familiar with guidelines development process might be aware about the GRADE framework. And because of lack of studies about use of SROM as OAT, this is not a GRADE-based recommendation. It's a consensus-based guidance document, and it really considered the experience and perspectives of the authors around each sub-theme with the support of a moderator. In terms of the evidence that we did find, there are 5 systematic reviews that have been published between 2011 to 2021, which reviewed the use of SROM as an OAT, and they all concluded that there were no differences in treatment retention or substance use between methadone and SROM. But they also do note that certainty of any treatment effect was limited due to the weakness of most study designs. Most of these were crossover studies switching from methadone to SROM with small sample sizes and followed people for short duration of time. Some of the key aspects that these studies looked at when comparing SROM to methadone or buprenorphine was looking at treatment retention, changes in substance use while being on SROM versus on methadone or buprenorphine, cravings, patients' treatment satisfaction, as well as impact on their mental health and chronic pain. And most of these studies found that SROM was as favorable as methadone or buprenorphine, and in certain criteria such as treatment satisfaction and patient self-reported improvement in their mental health more while being on SROM, as opposed to especially in crossover studies when they were switched from methadone. One of our first recommendation is that SROM should be offered as a treatment option to individuals who have a diagnosis of OUD and who are seeking to start OAT. And this should be done within the context of process for shared decision-making that considers individuals' health and circumstances, as well as the evidence, merits, and risk of each type of treatment. In terms of the safety and side effect profile of SROM, it is a full opiate agonist, so it is expected to have more side effects and greater overdose risk than a partial mu agonist such as buprenorphine. But otherwise, the adverse events are similar to that of a full opiate agonist such as methadone. The common side effects include sedation, constipation, and nausea. There was a crossover study that looked at when patients were switched from methadone to SROM, and they found no difference in adverse events that were reported by the patients. It can be a favorable option compared to methadone, especially on patients where there is a risk of QTC prolongation, as it contains limited risk of that, and it has fewer medication interactions compared to methadone. Some of the notable medications interactions mainly are with some benzodiazepine tricyclics and calcium channel blockers, and that mechanism is thought to be that these medication disrupts the metabolism of the slow-release oral morphine in the glucuronide process that happens in the liver. We're going to go through a case study and walk through how these recommendations apply to the clinical context. So Leo is a 27-year-old male, single. He lives in Toronto and works in construction. He's reconnecting with RAM Clinic today after 6 months. He shares that he has had an escalating pattern of fentanyl use over past 6 months, with his last use of 0.5 gram of fentanyl smoked today. He does not have history of intravenous drug use. He does report an overdose about a week ago, which prompted him to re-engage with clinic today. In terms of his other substance use history, he shares that he occasionally smokes a joint of cannabis at night, and last use was within past week. No recent stimulant use. He does drink socially at weddings or events, but denies any regular or problematic use, and he smokes about half a pack of tobacco per day. He denies any intentional benzodiazepine use other than, unfortunately, the contaminated supply of fentanyl. In terms of the past OAT trials, he shares that he has been on methadone in the past. He started when he was 20, and the dose was titrated up to 120 milligrams. He was switched to buprenorphine due to QTC interval prolongation on methadone, and he has been on buprenorphine for a period of time, and he has been up to the max off-label dose of 32 milligrams. He did experience severe nausea while he was on buprenorphine, and he states that he did not find it helpful to manage his cravings and withdrawal symptoms, and he stopped attending and engaging in care around that time. He has never been on depot buprenorphine, and he's not interested in trial of that. Today, he's reconnecting because he has recently heard about SROM from some of his friends, and he's wondering if it could be a helpful option for him. And his goal is abstinence. In terms of choosing an OAT, use of a decision aid tool to select an OAT agent is recommended. It can be really helpful for patients to see their options and also to see how the different drugs kind of compare in terms of their safety, side effect profiles, as well as differences in how they're taken, how quickly the dose can be titrated, and how quickly they can get carries while on certain type of OAT. And the documentation of the risk and benefit of this treatment, as well as the decision process, should be included in patient's clinical record. I'm going to just share the decision aid tool. So this was developed by Medify as part of the SROM for OAT recommendations, and it's a very helpful tool that takes through the summary of kind of what is the evidence that we know about the different OAT options that are available to the patients, difference in how it's taken, how often the person typically needs to take it in the context of when it's prescribed as an opioid agonist treatment, how frequently they need to attend pharmacy, as well as starting process, because sometimes that's really important for patients to understand. For example, for buprenorphine, about the different ways of starting either while the patient is on moderate withdrawal or starting microdose versus methadone or Cadian, which can be kind of started at any time, as well as understanding how quickly the dose can be titrated and how soon after they start on treatment with the dose titration, and they can start to feel effect of the medication. And if they need to go to like a special OAT clinic or where these medications can be prescribed, as well as cost, especially for patients who don't have medication coverage, sometimes can be a deciding factor when they're making a decision about which medication to start, as well as understanding the side effects as well as the risks, and understanding if there is other substance use in addition to OAT or illicit opioids, what kind of effect that they can expect. And there are some personal stories of patients who have been on these medications about their personal experience. This can be really helpful to either go through with the patient or to give this to the patient for information and go through it with them. Certain situation in which SROM can be more favorable option as opposed to buprenorphine or methadone can be patients with severe OUD and or high-risk opioid use and who prefer to start SROM as opposed to methadone or buprenorphine, or patients who are experiencing unacceptable side effects such as sedation or nausea with other types of OAT. And if they're experiencing ongoing cravings, withdrawal symptoms, and or high-risk opioid use while they are on methadone or buprenorphine and are looking for trial of an alternative medication. Patients who have contraindications to use of methadone or at increased susceptibility to developing prolonged QT or torsades when using methadone. Some of the absolute contraindication or the patient group that SROM will not be an option for is patients with hypersensitivity to morphine sulfate or any of the non-medicinal ingredients, patients with acute or severe respiratory depression, patients with asthma with severe bronchospasm, patients who have severe COPD, any sort of gastrointestinal obstruction, including ileus, and use of MOAI within the last 14 days. Thankfully, these medications are not kind of commonly prescribed or seen these days. Or patients with chronic kidney disease with eGFR of less than 50, because it is the metabolites are excreted renally. Some of the relative contraindications or precautions in the subset of patients that you will need to be very cautious if it is being considered as patients with GI issues that affect gastric emptying, such as if they have any obstruction, diarrhea, or abnormal gut anatomy, and that's kind of the way this medication is metabolized and absorbed. With eGFR between 50 to 90, because the renal function can acutely be reduced because of dehydration or medication, therefore putting patients at risk of M6G toxicity, which is one of the metabolites of morphine. And patients who drink alcohol, if there is irregular severe alcohol use disorder, it would not be a good option because the co-ingestion of alcohol with SROM can cause rapid increase in opioid plasma concentration and can put people at risk of fatal overdose. It is metabolized in the liver, so patients who have hepatic dysfunctions or patients who are at high risk for opioid toxicity, such as older age, COPD, sleep apnea, or concurrent use of medication that can cause rest depression. And if this medication is to be used or considered, lower starting doses are recommended and they'll need more gradual titration. While the product monograph states that SROM is contraindicated during pregnancy due to the risk of neonatal withdrawal syndrome, we know that withdrawal symptoms are associated with all opioids, and the benefit of OAT outweighs the risk associated with ongoing uncontrolled opioid use for pregnant person and pregnancy. So if a person becomes pregnant who is stabilized on OAT, it's not recommended to switch or taper their dose. In fact, during pregnancy, they might require higher doses. And I saw that there is, I think, a session after this about pregnancy, OAT during pregnancy. So there might be more information about this in that session. Some of the pharmacology consideration, SROM, it's the morphine sulfate sustained release oral capsule, and the brand name is Cadian. It's a long-acting, once daily, 24-hour formulation. You take it once a day. It is a full mu opiate agonist. And once you take the dose, usually the peak plasma concentration, the Tmax, is achieved within 8.5 to 10 hours. So comparison to methadone, for example, patients who have been on that before, the Tmax is usually 2.5 to 4 hours after taking methadone dose. And you can take it with food or without food. The 8.5 hours Tmax is if it's taken empty stomach versus 10 hours with food, and it's not found to be clinically significant difference. This is especially important. I've found patients who are on combination of methadone and SROM, they find that while from methadone, they get kind of that more immediate relief in terms of the withdrawal symptoms and cravings, and especially if they're struggling with withdrawal symptoms much later in the day, about like 8 to 10 hours after taking the dose, that the addition of SROM, they find it really helpful to relieve their withdrawal symptoms. The terminal elimination half-life of morphine following a single dose is usually 11 to 13 hours, so it's not as long-lasting versus 24 hours at steady state for methadone. Therefore, it also allows for the opportunity for the dose increases to be able to be done at a faster pace as compared to methadone. And the steady state is achieved within approximately 48 hours. And it does not have a ceiling effect because it's a full opiate agonist. It's metabolized mainly in liver. M3G and M6G are the main active metabolites, which are then eliminated via kidney. M6J in particular has potent analgesic and depressive effects. And for patients who have any renal impairment, it can accumulate quickly in their body and cause toxicity. So you need to be very cautious if you are prescribing it to somebody with renal dysfunction, especially for patients who are on hemodialysis or have significant impairment of renal function. Coming back to Leo, he's wondering about the starting dose of SROM and how quickly it can be titrated. He does have history of stopping treatment during the induction phase due to not finding treatment immediately effective in alleviating withdrawal symptoms or cravings. And just because you've worked with him before, you know he does not have any history of surgery or any renal or kidney impairment or any other absolute contraindication to use of SROM. So now I'll talk about when we're using SROM as monotherapy, what kind of starting doses we recommend using, as well as how frequently the dose titration can happen. In terms of the dosing, as with any OAT, the goal is to support the person in finding dose that works well to manage their withdrawal symptoms and cravings without causing excessive sedation or other adverse effect. We recommend that starting doses should be based on individuals' opioid tolerance and risk for toxicity. For patients with low tolerance or who are at high risk of toxicity, the starting doses can start at 30 to 50 milligrams. Patients who are at moderate tolerant, 100 to 150 milligrams starting doses are well tolerable. And patients who have established high opioid tolerance, we recommend starting doses of 200 to 400. The 400, that might be kind of the higher starting dose that some of you might be hearing. The number, we arrived at that number because we know that with the SROM using as adjunct therapy with methadone, usually the methadone starting dose is 30 milligrams with 200 milligrams of SROM. And in terms of the conversion rate, usually 1 to 6 or 1 to 8 is the acceptable conversion rate, and using like a more cautious 1 to 6 conversion rate. So 30 times 6 plus 200 of the SROM, that's about 380 milligrams. So from our clinical experience, patients who have really high opioid tolerance, they tend to do well on starting at 400 milligram dose. There is no maximum dose for SROM, although the literature describes highest dose in 1200. These studies or data is pre-fentanyl era, but mainly from heroin or prescribed opioid misuse patients group. In our clinical experience, patients who have high opioid tolerance often requires doses above 1200 milligrams to stabilize, to manage their cravings and withdrawal symptoms due to that high risk or high tolerance developed as a result of sustained exposure to fentanyl through the unregulated drug supply. In terms of the dose titration for patients with low tolerance or high risk of toxicity, and as I mentioned before, usually steady state is achieved within 48 hours, the dose can be titrated 50 milligrams every 48 hours or even lower based on patients' tolerance or response to the medication. For patients with moderate tolerance, the dose can be titrated by 50 to 100 milligrams every 48 hours. For patients who have established high tolerance, for example, who are using fentanyl daily in large amounts, 100 milligrams daily or 200 milligrams every 48 hours up to 800 milligrams is well tolerable. Once you reach 800, then we suggest doing a more gradual titration of 50 to 200 milligrams every 2 days if further dose titration is indicated. In terms of the dose titration planning, you should always consider the risk of ongoing opioid use, i.e. overdose while off OAT, and treatment discontinuation, and take into account the tolerance this person has and the need to stabilize effectively. And it's really that fine balance of finding a therapeutic effect without causing oversedation or adverse effects. Some of the pharmacy consideration when you do a script for SROM, like other OATs prescription, it should include a start and stop date, as well as indication for if it's daily observed dose and if there is carry doses, which day the carries can be dispensed. It comes in 10, 20, 50, and 100 milligram strength capsules. And I find it helpful to include on the script that the pharmacist can use whatever combination of strengths is available in the pharmacy to make the total daily dose, rather than specifying the individual number of capsules for each strength, because the pharmacy inventories may vary. For example, if person is on 200 milligram dose and you put 2 tabs of 100 milligram, they might be back and forth of packs as if they don't have 100 milligrams strength in stock. But if you write to use the combination of what they have in stock, then they can calculate and administer appropriate dose. The capsule do not need to be opened with pellets and poured into cup for observed dosing. The capsule can be given as whole as observed dosing, followed by a drink. And for people who take SROM and methadone together, it's common to write that methadone should be taken after the SROM capsule. And the reason for this recommendation about not opening and putting the pellets in the cup, first of all, it really creates a burden on the pharmacy to have that additive step. There have also been reports of the pellets getting stuck in the cup and due to static and patients not getting full dose, or in the past, I think some guidelines have recommended mixing it with yogurt or applesauce, and pharmacists have either not had those things on stock, or patients also feeling stigma due to taking medication in a different or unique way. Now, coming back to Leo, he has started on SROM and has currently on 600 milligrams daily observed dose. He's gradually reducing his fentanyl use. He's now reduced down to about 1 to 2 points per day smoking. He is not currently using other substances. You receive a fax from pharmacy that he missed 3 consecutive doses, and asking for instructions on how to proceed. We recommend that for the missed dose management, the clinician should review case-by-case basis, and you can use a modified approach in consideration of individual factors that affect opioid tolerance. In general, we suggest following the Medify recommendations for missed doses with methadone, which is no dose adjustment is required for up to 3 consecutive missed doses. And if they miss 4 consecutive doses, then to reduce the dose by 50%, or to initiation dose, whichever is higher. And if there's more than 4 consecutive missed doses, the patients will need to be reassessed and restarted on SROM. And this is just the same information in the table form, especially for patients who are on SROM under 800 milligram, if there is still ongoing high opioid tolerance due to concurrent ongoing use of illicit opioids, and for patients that you find it's really hard to get them stabilized on a therapeutic use, using this can be really helpful without that constant cycle of start and restart with the traditional 2 missed doses, 40% reduction. If it is somebody who has been on a dose higher than 800 milligrams per day, or somebody who is at risk of loss of tolerance pretty quickly due to their low opioid tolerance, then we recommend reducing dose by 40% after 2 missed consecutive doses. So Leo continued with the plan. He is stabilized on SROM 1400 milligrams for 3 months. He has not missed any doses. He has not had any substance use in 8 weeks. He has stable housing. He's working full time. He does find going to the pharmacy every day is barrier in terms of being able to attend to his other life and duties. And he is wondering about take-home doses for SROM. In general, we recommend that clinician can apply the modified methadone carry doses to the carry doses for SROM, but really it's a really individualized risk-benefit assessment. Carries usually are not appropriate for people who have been on SROM for less than 4 weeks or who are unable to store medications safely and who continue to use substance in high-risk ways, for example, recent overdoses or blackouts, who have unstable mental health concern or frequently missing doses and appointments. We recommend that for patients who are attending appointments regularly, who are taking their doses consistently, or not using substances in high-risk way, up to 3 non-consecutive carries per week can be appropriate once they have been on SROM for a minimum of 4 weeks, and if they're able to store their medication safely. With these conditions, the carries are used to assist with maintaining patients in treatment as well as building stability outside of a contingency management framework. And 4 to 6 carries may be appropriate for people who are quite clinically and socially stable. And this number is based on the increased risk associated with greater number of carries, particularly consecutive carries, and aligns with consistency management practice. And the expectations include minimum of 12 weeks of stability on SROM, effective management of small number of carries, and minimal substance use with no blackouts or overdoses in the last 3 months. There is really no literature available for use of more than 12 carries for SROM, and given the potential risk associated with greater amounts of take-home doses, we recommend max of 6 take-home doses for SROM. Although there are certainly cases where you might need to assess case by case the benefit of that person having carries based on their engagement in treatment and stability, they might be appropriate for more or less carries. And it's really recommended that you should use clinical judgment and personal circumstances in context of a therapeutic alliance between the patient and prescriber, depending on individual circumstances. In addition to the usual assessment of risks and benefits of take-home doses, clinicians should particularly assess the individual's history of injection drug use. The beads in the SROM capsule, it can be opened and mixed with water to be injected, and decision about carry doses should carefully weigh the benefit of carries against the risk of injecting SROM. And some of the other consideration, as I mentioned, the beads in the capsule can be crushed and dissolved for injection. And there was a study published in France that looked at patients who one of the main routes of diverted SROM use was via intravenous injection use. And another study in France reported that there was a widespread diversion of SROM prescribed as OAT in France, and they found significantly higher rates of unintentional opioid overdoses, all-cause mortality, hepatitis C seroconversion, hospitalization, and thrombotic complications compared with people on buprenorphine and methadone. So really the decision about carry doses should carefully weigh the benefit of SROM carries against the risk of injecting SROM, and you should have a frank conversation with the patients about the risks associated with intravenous drug use of SROM capsules. Now switching gear, I will go over when you are prescribing SROM as an adjunct therapy with methadone, what kind of starting doses you can consider, and whether to continue or stop, and how to assess that. For people with high opioid tolerance who are choosing to start methadone as their primary OAT, co-prescribing SROM has been suggested as an option and has been found really helpful to achieve therapeutic OAT doses more rapidly, as maximum initial methadone dose have historically been capped at 30 milligrams per day. In this context, you can start patients on methadone 30 alongside with SROM 100 to 200 milligrams per day. And usually the SROM dose can be increased every 48 hours by 100 milligram increments. And SROM can either be continued on if the patient is really doing well on that combination, or if they're interested in monotherapy, the SROM can be tapered off once the methadone dose is stabilized. And now we'll just look at the process of switching between different OAT medications. In terms of converting from methadone to SROM, it can be made gradually with the cross taper, where you gradually reduce down the methadone dose as you are titrating up the SROM dose, or abruptly with stop and start approach. There is no clear evidence for one approach being more preferable over the other. However, from clinical experience, patients do tend to tolerate the cross taper better versus the abrupt stop and start approach. The abrupt start and stop approach, it might result in higher rates of withdrawal, and especially while the doses are being adjusted and put patient at risk of destabilization. This approach might be more appropriate in a monitored setting where withdrawal can be managed with short-acting morphine. Individual circumstances such as medical stability, tolerance, and experience with SROM and opportunities for monitoring and reassessment should be considered when you're considering either to do a cross taper or to do the stop or and start approach. Usually the final doses of SROM are between 1 to 6 to 1 to 8 of methadone to SROM. There is an unpublished trial where they recommended, this is one of the sample cross-taper titration plan, reducing the methadone dose by 50%. And then if you're targeting 1 to 6 ratio, then the final dose you're hoping to reach is 600. So starting at 25 to 30% of that while you're gradually titrating the methadone, reducing the methadone dose and continuing to titrate up SROM. And once a methadone is stopped, seeing how the patient is doing at that and if they need further adjustment. This is another example. Here it's about the stop and start titration. So as I said, in literature, the usual 1 to 6 or 1 to 8 conversion rates have been reported. So if you wanted to do it more conservatively, you can do the 1 to 4 ratio. So methadone 100, stopping it, starting SROM at 400, or if it's somebody who has a higher opioid tolerance and you don't want them to be going through a lot of withdrawal, you can also consider doing the 1 to 6 ratio switch and then gradually titrating the dose and reassessing. In terms of converting from buprenorphine to SROM, there is no established conversion rate. There was one recent study that suggested initial ratio of 1 to 42 and final ratio of 1 to 58. So for example, based on those numbers, there will be 8 milligrams of buprenorphine is equivalent to about 338 milligrams of SROM. However, because there's really very limited evidence about these conversion ratios, we recommend assessing individuals' level of tolerance and toxicity risk. For example, if it's somebody who has continued to use fentanyl while on buprenorphine, they have higher opioid tolerance, and then somebody who has been stable at 8 milligram dose, for example, not using any other opioids, they might not need the same amount. At the same time, the increased risk of respiratory suppression, especially going from partial opiate agonist to full opiate agonist, should be considered, and due to that, reducing the starting dose 25 to 50% to account for differences in cross tolerance. SROM can be started the day after the last buprenorphine dose, so taking the dose and then 24 hours later starting SROM, there is no risk of precipitated withdrawal, and then titrating the dose every 48 hours as per the usual protocols. In terms of converting from the depot buprenorphine to SROM, there is no current guidance or established conversion ratios. We recommend that once the withdrawal symptoms start for patients who are on depot buprenorphine and looking to start to SROM, to start at lower doses of 30 to 60 milligrams and titrating every 48 hours based on their tolerability and the effect. And the opposite switch of converting from SROM to buprenorphine, SROM is a 24-hour kind of formulation based on the terminal half-life. You can do a standard induction where you stop SROM 24 hours prior and then doing the regular induction of buprenorphine. However, if it is a patient where avoiding withdrawal symptoms is a priority, you can consider micro-induction as well. In terms of the urine drug screen, we recommend similar approach for patients when they're prescribed SROM as the recommended urine drug frequency for patient on methadone. So during the titration, stabilization, and building carry states, usually up to 4 times a month, or typically in conjunction with if you're seeing them weekly, there should be regular urine drug screens as part of safe opioid prescribing. And if there are long-term carries of 6 or more, usually once every month or every 2 months, typically in conjunction with the clinical assessment, and more frequently if clinically indicated. And in the maintenance phase, similarly monthly or more or less frequent as clinically indicated. Just some of the expected, what you might see on urine drug screen. If your patient is on SROM, the morphine will test positive. Hydromorphone is a very small metabolite of morphine. So patients who are really on really high doses of morphine, you might see a small amount of hydromorphone and trace amounts of codeine. And this is just looking at, for example, like historically, especially with carries in heroin era, I was concerned like not being able to distinguish morphine from heroin in urine drug screens. And with the mass spectrometry, you should be able to see the difference, what's expected to see with SROM UDS versus for somebody who's using heroin. Unfortunately, we have had some drug shortages for SROM, so it's important to kind of know what to do if that kind of situation happens again. If SROM is unavailable, the doses can be converted to Amslon and divided into twice daily dosing, and care must be taken to avoid double dosing, as Amslon releases morphine over 12-hour period, and it's twice a day dosing. There's no adjustment or reduction required. So you will just convert, for example, if somebody is on 200 milligrams of SROM, you'll just do that divided into BID dosing. So that'll be 100 milligrams BID Amslon. You can do observed dose in the morning with carry in the evening. However, if it's somebody where they're really unstable and not appropriate for carries, you can do observed dose twice a day or consider switching them to another OAT. And to note, most of the literature on SROM as OAT is based only on the 24-hour formulation, not on the other intermediate acting formulations. In summary, we recommend that SROM should be offered as a treatment option to individuals who have a diagnosis of opioid use disorder and are seeking OAT. And starting doses should be based on individuals' opioid tolerance as well as their risk of toxicity. For missed dosing, we recommend consideration of individual circumstances, including their stability, ongoing substance use, and impact of reduced use, and other medical factor when determining this dose. For take-home doses, we just suggest using similar framework described in Medify's recommendation for methadone carry-home doses. And when transitioning between OAT medications, the cross-tapering may be more appropriate rather than the abrupt start and stop transition. Thank you so much, everyone. That's it for the presentation. And we have a lot of time now for questions. You can type in the chat. I see that there's a question. SROM and hydromorph IR, how is dosing determined? In terms of the SROM, like I'll go back to the slide here, if I understood your question correctly. So we recommend the starting doses based on individuals' level of tolerance and risk for toxicity. So somebody with low tolerance starting at 30 to 50, with moderate tolerance 100 to 150, and with high tolerance 200 to 400 milligrams. For the hydromorph IR, it's not commonly prescribed as OAT. Perhaps you're referring to the safer opioid supply. And I have heard, it's not something I've personally prescribed, but I have heard that sometimes upwards of like 32 tabs of 8 milligram dose are kind of gradually titrated to that and maybe more. I think there are many resources available online if you were looking for more information specifically for that.
Are there any other questions or comments for Karen? We have a few more minutes, so if you have any other questions or comments, please feel free to post them in the chat. And Karen, if you want to leave your email address in case there's any other thoughts or questions that come afterwards.
Sure, absolutely.
Yeah.
I'll add my email in the chat button here. If you think of any questions after the presentation today, feel free to send me an email.
Okay. So thanks so much, Karen. That was a really interesting and informative presentation. And I just want to thank Karen again, and I want to thank everyone who joined this session. I hope you enjoyed it, and I hope you enjoyed the next one that you attend, and I hope you have a really great weekend. Thank you.
Thank you so much.